Thank you very much, and thank you for the invitation to what's been a really inspirational conference for me. I'd like to start by acknowledging the traditional owners of the land on which we meet, and to pay my respects to their elders past and present, and of course to the future, who are our children. I'm from Sydney, and as you'll see from this photograph, I took this photograph recently when I was in the city. And Sydney is a beautiful city, and this is a beautiful opera house. However, it's important to... Can I move the slides? It is important for us to look back before we can look forward. And I just want to raise that this building was extremely controversial. It took 14 years, not the expected 4 years to build. It was over budget. And in the end, we got rid of the architect. So it is important to consider what's happened in the past. And when it comes to alcohol in pregnancy, it's also important to look backwards. This is an etching by Hogarth done in the 1700s of Gin Lane in London, where women were drinking heavily during the pregnancy, and he depicts children with what we now know as fetal alcohol syndrome. So it's important to remind ourselves, looking back, that we've been slow to acknowledge the truth and the harms of alcohol. Ken Jones was the first person to describe fetal alcohol syndrome in the English literature in the early 1970s. And decades later, he looks back and says, why haven't women still got the message that alcohol can harm the unborn baby? And back in 2004, a colleague of mine, Carol Bauer, and I wrote an article, Fetal Alcohol Syndrome in Australia, Is It Fact or Fiction? And at that time, which is not that long ago, there were less than 10 papers in the Australian literature on either alcohol use in pregnancy or fetal alcohol syndrome. So looking back, it's important to acknowledge that Australia has made gains, but we're not there yet. And I suspect New Zealanders would agree that you're in the same position. So what do we mean by fetal alcohol spectrum disorder, which is what we now call it? This is an acquired brain injury caused by prenatal alcohol exposure and characterised by severe neurodevelopmental impairment. It manifests as both physical features and predominantly problems with development, learning and behaviours. And alcohol exposure in pregnancy has lifelong impacts. But of course we need to acknowledge, and we heard this from Laura today, that the outcomes for any child exposed to alcohol prenatally can be modified by both living in a protective, nurturing environment or by experiencing adverse childhood events or early life trauma. And I'm very pleased that you've asked for fetal alcohol spectrum disorder to be included in this conference, because although you may not feel that it's relevant to you in your practice, I can assure you that every one of you will have seen people with fetal alcohol spectrum disorder, or you will have seen mothers or fathers of children with fetal alcohol spectrum disorder, or indeed children, because many of these people are still undiagnosed. So you might ask, well, surely after all these centuries, women are still not drinking alcohol in pregnancy. And as Doug Selman said, not in his lecture yesterday, but I think in a lecture at ASPAD last year, a glass of wine in a woman's hand is the new symbol of success. And that is very sad, because it's actually people like us, the perhaps educated people, not necessarily people living in disadvantage, who are the ones who are drinking most in pregnancy. So alcohol use in pregnancy is common, although the WHO says about 10 to 25% of women across the world drink alcohol in pregnancy. That, of course, takes into account countries where women don't drink at all. We know in Australia 50% of women say that they drank during pregnancy in a national survey before they were aware of that pregnancy. But we also know from two cohorts we've got, both in Melbourne and in New South Wales, that about 60% of women are drinking during pregnancy, often at very high levels before they realise that they're pregnant. Now, in some Aboriginal populations where drinking has been common over decades, we know that high levels of drinking occur, about 55%. So the proportion is not higher in Aboriginal than non-Aboriginal women. However, the pattern of drinking is often different. It's often a binge drinking, high level pattern. And as I've mentioned, it's the older women, the women of higher educational levels and socioeconomic status that are more likely to continue drinking during their pregnancy. So we might ask, well, why do women drink in pregnancy? Certainly no women drink to intentionally harm their unborn child. We know from national surveys that still about 30% of women in Australia are unaware of the harms that it might cause, and about 20% have a tolerant attitude to alcohol use in pregnancy. So if you describe a very pregnant woman in the pub, about 20% of people will say that's their business. It's a free world, they can do what they like. And what we've found is that the attitude to drinking in pregnancy, rather than knowledge of the harms or educational level, is what determines whether women drink in pregnancy. And that poses a real problem for us as public health and professionals and drug and alcohol professionals and clinicians. It's very much more difficult to change attitudes than it is to change knowledge, and knowledge doesn't correlate with behaviour. So we've got a bit of thinking to do there. Now, Indigenous women in Australia are much more aware of the harms of alcohol use in pregnancy, and they tell us quite clearly that the reasons they drink in pregnancy are their current stress due to disadvantage, domestic violence, overcrowding, etc., all the things we've heard repeated in many of the talks at this conference, and also the historical trauma that they've suffered. The other problem is that alcohol in pregnancy is a taboo subject. Clinicians are very reluctant to broach it, perhaps because many clinicians themselves drink. They're worried about stigmatising or frightening pregnant women. They're worried about damaging the doctor-patient relationship. But furthermore, they say they don't have time, they don't know how to record it, they don't know where to refer, and many are unaware of the national guidelines. In contrast, when we survey women, over 90% of them want to be asked about alcohol in pregnancy. Furthermore, over 90% want to be advised not to drink during pregnancy. So there's this real mismatch between clinicians and women. Women want to know, and they want to be given clear, firm advice. And indeed, we have clear advice. Our national guidelines, similar to the New Zealand guidelines, suggest that the safest option for women planning a pregnancy or during pregnancy is not to drink alcohol. And this is quite consistent with international guidelines such as those developed by the WHO, which recommend that we ask all women about alcohol in pregnancy. We advise on the harms, we assist them to stop drinking. If necessary, we provide a brief intervention or detoxification, and we look out for neonatal abstinence syndrome, and we treat the infant for withdrawal. We advise women that alcohol stays in the breast milk for 10 hours, and that the best advice is not to drink while you're breastfeeding. And if we're concerned about a baby who's been exposed, we refer them to the paediatric service for assessment. There are good guidelines, and I'm sure similarly exist in New Zealand, for how to support women who are drinking during pregnancy. So why the concern? Why are we worried about alcohol use in pregnancy? It's gone on for centuries. Well, it's important to look back and know that what happens in the pregnancy explains both our current health and our future health. We know that alcohol is neurotoxic. That is, it damages the developing brain and nervous system. We know it's teratogenic. That is, it disrupts the development of the normal organs of the body, and particularly the brain. And we know that it has epigenetic effects. That is, it can alter the chemical composition of the DNA and predispose the fetus to a whole range of organic diseases later in life. The problem is that in Australia and New Zealand and almost everywhere in the developed world, we have a problem with drinking. We have a problem with binge drinking, increasingly in women, and we have a problem with unplanned pregnancy. We've got very effective contraception, yet in Australia, 50% of pregnancies remain unplanned. And as I've demonstrated to you, alcohol in pregnancy is common. So what happens when we drink in pregnancy? If I have a glass of wine in pregnancy, I will develop a blood alcohol level which will be transmitted almost immediately across the placenta to the unborn child. You know how you feel if you have a couple of glasses of wine on an empty stomach. Imagine what that's doing to a developing brain. The problem is that we can't predict harm in an individual person, because you and I might have the same amount to drink and have completely different blood alcohol levels. I'm older than you, I've got a different body composition, I've got different genetics for metabolising alcohol, different nutritional status, different liver function, different pre-existing health problems. So when people say, how much can I drink, really we should be taking the precautionary advice that the safest option is not to drink in pregnancy. We cannot predict the risk in an individual. And I put this slide up just to remind you that certainly when I was having babies, the advice was you could drink after the first trimester. And of course, if you drink in the first trimester, that's when you will get birth defects, because that's when all the bodily organs are forming, the face is forming, etc. However, the brain continues to rapidly develop through the second and third trimester. And even just before delivery, those connections between the sides of the brain are forming. Hence, the brain can be damaged at any time during the pregnancy, and we need to keep reminding our clients of this. Now, prenatal alcohol exposure does more than just cause fetal alcohol spectrum disorder. And I just put this slide up just to remind you, because you may not be aware that even in the absence of fetal alcohol spectrum disorder, alcohol use in pregnancy at moderate levels can cause a whole range of conditions: birth defects, cerebral palsy, intellectual disability, language delay, etc. It can cause small heads. And if you follow these children later in life, they have much higher rates of contact with child protection justice and out-of-home care. They have poor school attendance and they have poor academic outcomes. So that's even before you get to fetal alcohol spectrum disorder. Now, alcohol, as I've said, damaged the brain, and you don't have to be a neurosurgeon to realise that that brain on your right is damaged and will not function well. However, the brain on the left, although it is of normal size and looks macroscopically normal, may not function well. So alcohol can cause brain dysfunction and structural abnormalities. And these may or may not be associated with physical features such as facial features, birth defects, and growth impairment. So how is the diagnosis of fetal alcohol spectrum disorder made? And I think at this point I just want to thank the Ministry of Health for sponsoring a 2-day workshop which we're having on Monday and Tuesday here in Auckland, bringing multidisciplinary teams of clinicians in to think about how can we most efficiently and effectively and in a standardised way make this diagnosis. Now, we've been assisted by a government-funded guide to the diagnosis of fetal alcohol spectrum disorder, which we've recently developed. And this takes you through the components of the diagnosis. So the first thing is we need prenatal alcohol exposure. We need to document severe neurodevelopmental impairment across several domains of brain function. And we look for facial and physical features, but these are not required necessarily for the diagnosis. Now, you're all working in the addiction field. You will know it's important to ask about alcohol, but to ask in a standardised and meaningful way. We use the Audit C, which gives us a risk score. We then have advice consistent with the risk level, and we alert people to where they should be referring mothers. However, often, particularly as a lot of the kids we see are in foster care or in juvenile justice, we don't have access to the biological mother. So it's very important for us to go to child protection, police and other records to try and get evidence of alcohol exposure or to get first-hand observation of what the woman did during the pregnancy. Now, when we assess neurodevelopmental impairment, we use a multidisciplinary team and we assess a range, 10 domains of function. These include things like looking, is the head small? Has the child got seizures? What are the child's motor skills like? What's their speech and language like? What's their executive function? Can they look after themselves? Have they got attention deficit disorder? Have they got hyperactivity, poor impulse control? And when I say severe impairment, using standardised tests, we really want to see that these children are performing very badly, 2 standard deviations below what you would expect for a child of that age. And the third component is to look for these facial features. Now, if they're present, of course, it's very helpful, because if you have the 3 facial features I'm going to tell you about, there's a very high sensitivity and specificity for this disorder. However, these facial features will only occur in a very short period of exposure during embryology. So, what are the three facial features? The first one is a narrow eye opening. That's because alcohol affects the forebrain, which affects the development of the optic nerve in the eye. And if that's small, the eye opening will be small. The second feature, and you can perhaps look at your neighbour as I'm talking about this, is don't be alarmed if they've got one feature, is this thin upper lip, very narrow upper lip. And the third feature is an indistinct philtrum, so the absence of these two grooves that you normally see coming down. And you'll see from that bottom picture that these features hold true whether you're looking at a Hispanic child, a Caucasian child or an Afro-Caribbean child. And indeed the work that we've done in Aboriginal communities suggests that they hold fast in those communities. Now I put this up because this is some work we're doing at the moment on a cohort of pregnant women whose babies are now a bit over 1 year of age. When they were 1 year of age, we used a very sophisticated 3D imaging method using 70,000 spots of light on the face to look at the contour of the face. And interestingly, we found that we could pick up alcohol exposure in that first trimester by looking at differences in the contours between children who were exposed and not exposed to alcohols. And there were significant differences in those exposed. So I put this up really to say that as we get more sophisticated with using this sort of 3D imaging, I think there'll be better diagnostic tools than we have available currently. I put this up just to remind us that adverse child experiences are always documented in our notes. And we're looking for evidence of abuse, neglect, dysfunction in the household. And you've heard a lot about ACE scores from Laura today. And at the end of the day, we come up with a diagnosis of fetal alcohol spectrum disorder with the 3 sentinel facial features, or fetal alcohol spectrum disorder without those features. Now, I make the diagnosis sound relatively straightforward. It's not. It's never straightforward. Often we don't have the information we need. There is no diagnostic test. We have to exclude genetic and other disorders that might cause neurodevelopmental impairment, and we have to be sure that we've got good evidence of alcohol exposure. So the sort of child that presents to me will be a child like this one. He presented at 3 years of age. His mother was a young mother who drank heavily during the pregnancy, such that the father got custody of the child at birth. He was preterm, low birth weight, irritable, had a seizure in the prenatal period and difficulty feeding, and subsequently he developed poorly, problems with speech and his motor function. He had a squint, he was emotionally labile, he had problems with attention and hyperactivity. He was a risk taker. He repeated mistakes. Each morning he put his clothes on top of his pyjamas, and his stepmum would say, no, you've got to take the pyjamas off first. And he was expelled from preschool. Now, this is not uncommon for the children that we see, because the behavioural problems that they have are often the key problem that impacts their learning and their living at home. He actually had a small head. We measure this and plot it against normal values. And he had small eyes and the other facial features that I've described. And when I saw him a few years later, he was failing in primary school, which leads you to think, well, what does the future hold for a child like this? And indeed, we know that when you follow children with fetal alcohol spectrum disorder, they do have problems in adulthood. And that really makes the case for prevention. These outcomes can be modified, but not necessarily prevented. So collectively, adults with fetal alcohol spectrum disorder will have higher rates of mental illness, substance abuse. They will often be unable to live and work independently. And although they can be, their outcomes can be optimised by early intervention. This disorder, of course, if you're arguing with politicians, there's a very good economic argument for trying to prevent this disorder, because it involves community, disability, justice, education and health services at really huge expense. And what's just coming out very recently is that the life expectancy for adults with fetal alcohol spectrum disorder is severely impaired, an average of 34 years. Now, these deaths are often from suicide, accidents, alcohol and drug use, but increasingly we're seeing that there are higher rates of organic disorders, lung disease, kidney disease, heart disease, hypertension, etc., in adults, and we're wondering whether this is programming through an epigenetic mechanism from the alcohol exposure in utero. So the results are still coming on that. Nevertheless, adverse experiences, as I say, increase the risk of these adverse outcomes in adults, and a stable supportive environment will minimise that. Now, it's very interesting to hear Richie Hardcore yesterday or last night saying his dad was an alcoholic, his granddad was an alcoholic. What are we doing for children who are living in these environments? Even if they don't have fetal alcohol spectrum disorder, he said, I wish there'd been some services there for me when I was young. And in fact, the service that we run at the Children's Hospital at Westmead, the Cicada Centre, for the care and intervention for children and adolescents affected by drugs and alcohol, combines 3 clinics. The first is the Fetal Alcohol Spectrum Disorder Assessment Clinic. The second is a clinic for adolescents who are using drugs and alcohol. And the third is a clinic for children who are living in households where their mums and dads are using drugs and alcohol. And by combining these services, often there's an overlap between our patients. But we really do hope to provide some of that support that children need. And I think in general, we really underestimate the impact of alcohol and other substances on children. That applies to drowning, to motor vehicle accidents, to abuse and neglect, and let alone the emotional trauma that they suffer. So who is most at risk of fetal alcohol spectrum disorder? This is fairly obvious. Siblings, children whose mums have alcohol dependency, but increasingly in my practice in Sydney, children in foster and adoptive care, children in institutions, some Indigenous communities, not all of them, and children in the justice system. We are currently running a national surveillance study where paediatricians report to us every month whether they've seen a new case of fetal alcohol spectrum disorder. And in a 3-year period, I think we had over 250 cases. Slight predominance of boys. The mean age of diagnosis is about 8, so primary school. 57% of these kids are Indigenous. Half of them live in out-of-home care. 15% have a sibling with FASD. So we've missed that opportunity to prevent the adverse outcome in that sibling. A quarter of them had microcephaly, so this suggests we're really seeing still the extreme end of the spectrum. And they often have impairment in executive function, the capacity to plan and conduct sort of complex tasks, adaptive behaviour, language, attention, and academic achievement. But it is important to make the diagnosis one. For people like you, it can help the mother. It may prevent a subsequently affected sibling. It helps us identify the strengths and the needs of children that we assess. It helps guide early intervention, and importantly, it allows us to change our expectations of the child and accommodate them in education and justice systems. It enables families to apply for funding and peer support, and it does raise community awareness. And parents repeatedly say that understanding that the behaviours are a result of brain damage, not willfulness, shifts the thinking that this person with FASD is a problem rather than they have a problem. What do we know internationally about fetal alcohol spectrum disorder? Well, that it affects probably 8 cases per 1,000 and that there are over 600,000 cases annually born. It's the leading cause of intellectual disability and of birth defects, and yet these are likely to be underestimates. Now, the New Zealanders may know, but I couldn't find any good prevalence or incidence data in New Zealand. The data I found was from 1993, a one-off survey nationally where 62 cases were reported, and I'm sure that we'll be talking about that in the next couple of days. Way to monitor what is the prevalence of fetal alcohol spectrum disorder currently in New Zealand, and how can we monitor the changes in trends. Now, I just want to turn briefly, because there's been a lot of focus here on Maori and Pacific Islanders, and I wanted to turn quickly to the way in which remote Aboriginal communities in Western Australia have tackled this problem of fetal alcohol spectrum disorder. You may not realise, but it was not until 1967 when we had a referendum that enabled Aboriginal people to be recognised as citizens, to have the rights to vote. With citizenship, however, came the right to be paid. So effectively, we don't talk about it in the terms of slavery like you do in the US, but that's exactly what it was. These people were working unpaid. As soon as they became citizens, they had the right to be paid. They were therefore cast off their traditional lands into shanty towns. They were prevented from speaking their language. They were prevented from conducting ceremony. They were taken into mission schools or stolen away from their mothers and taken many thousands miles away, often to live in white families. They have persistent inequality in health and education. Because there was no opportunities for employment, they were entitled to the dole or sit-down money, and that bred resentment and racism. And with citizenship came the right to buy alcohol. So all of a sudden, in these traumatised communities who are currently disadvantaged, there was the right to access alcohol. So the communities that I've been working in are that red dot. That's about a 5-hour flight from Sydney and then a 5-hour drive out from Broome. And we've been working in 45 very remote communities of the Fitzroy Valley. We were invited to come in by the Aboriginal people, otherwise we couldn't have gone there, to assist them in strategising how would they deal with alcohol in pregnancy. So in 2006, the community was in crisis. The women decided enough was enough. They fought for alcohol restrictions, and then they turned around and said, well, what's happening with our children? Why are they struggling in school? Could this be fetal alcohol spectrum disorder? And June Oscar, who was a leader in that community and in fact is now the Human Rights Commissioner in Sydney for Aboriginal and Torres Strait Islander people, described fetal alcohol spectrum disorder as a tragedy that somehow transcends other aspects of grief and trauma. Here is innocent young life, the future of our people, and all that goes with it, our culture, our language, knowledge about the laws of our country, being born into this world with brains and nervous systems that are so impaired that life for that person from birth to death is cruelly diminished. And this is particularly pertinent in a community where there's an oral culture. So the stories, the language, the songs, the traditions are passed down. And June has described this as a humanitarian crisis. So they developed a strategy to address fetal alcohol spectrum disorder. They called it Maralu, which is a Bunaba word, which means precious, worth nurturing, which is how they consider their children. And the themes were diagnosis, prevention, and support for families with FASD. And then they invited us to do the Little One project to look at the prevalence of alcohol in pregnancy, fetal alcohol spectrum disorder, and early life trauma. So this was a community-initiated, community-led project partnering with universities and clinicians. And really at the end of the day, although we discussed at length the potential risks to the community of this, they decided that if there was no data, there was no problem, and there would be no action, and that they felt that research data would allow communities to take control, that very important self-determination. So what did we find? Well, we found that 55% of women said they had drunk during the pregnancy, 93% at high risk, mostly throughout the pregnancy. And what I mean by high risk is, and you'll see perhaps on that right-hand bar, the far bar, that's 10 or more drinks. And the most common pattern was 10 or more drinks 2 to 3 times a week, but some women drank 10 or more drinks on a daily or almost daily basis. And not surprisingly then, we found that 1 in 5 of these children had fetal alcohol spectrum disorder when we came back with a multidisciplinary team, and they had all the behavioural learning, physical and, and other problems that I've mentioned that might be associated with this. But we also recognised that 90% of these children had suffered early life trauma. 50% of them had at least 2 early life stresses. 20% had been in touch with child protection. And those who had fetal alcohol spectrum disorder with early life trauma, not surprisingly, had worse outcomes. Nevertheless, the community felt there were significant health benefits from children in getting a very full assessment that they really hadn't had access to before. Ears and eyes and hearts and lungs and everything. Some of these children had a diagnosis of fetal alcohol spectrum disorder, as I said, 1 in 5, and they had management plans developed, referrals made, treatment initiated. The community was praised for addressing this taboo subject, but a warning came quite clearly: we mustn't be stigmatising Aboriginal communities, because this is likely to be a condition that is hidden in our own communities. There was a lot of education that came out of this project, and community awareness, television programs, videos made, etc. The data allowed us to drive the maintenance of community-led alcohol restrictions, which I have to tell you have been challenged repeatedly, even last year. There was also international recognition for the community, and we were invited to present our data at the UN at the 11th Permanent Forum on Indigenous Issues, where it was very good for women from the community to realise that this was a problem common to Indigenous communities who'd been suppressed throughout the world. And it resulted in a lot of community initiatives: an early childhood centre, an early learning centre, a family violence centre, legal aid, alternative education pathways for children who wouldn't succeed in the school system. Resources for educators have been developed. We've initiated a positive parenting program where we're training local women to train local mums to deal with some of these problems early, to hopefully prevent the adverse trajectory of these children. And perhaps most importantly, these data grabbed the attention of politicians and contributed to a national inquiry, which in the end has resulted in $27 million to address fetal alcohol spectrum disorder in Australia. And we have just had a second strategy released, which goes for the next 10 years. Now, not all is rosy, because of course you can't suffer severe early life trauma and a brain injury and expect everything to just turn out well. And you know, our last speaker, I can see nodding, would understand that many of these children, despite all good efforts, end up in the contact with the justice system. And of course, in remote communities, there is nowhere to put people or nothing to do with people except in the jail. And that really needs to change. So this is one of the children in our cohort, was stolen a car, was driving it with 7 other kids in the car and crashed, and another child in our cohort was killed. There's been problems with break and enter and other crime in the community. And in fact, this is entirely consistent with a study that's just been done by my colleague Carol Bauer in the only juvenile justice system in Western Australia. And they found that 1 in 3 children had fetal alcohol spectrum disorder. And that's probably an underestimate, because for many of them they couldn't get an alcohol history. And this raises the whole issue of justice and fetal alcohol spectrum disorder. These children do not understand the consequences of their actions. They do not learn from their punishments or, you know, how the way in which they're treated. They cannot articulate what happened. They are easily led. They're poor witnesses, and they really shouldn't be dealt with in the justice system. And yet in Australia we have many examples of children being falsely imprisoned. The Royal Commission into Children in Juvenile Detention, which was held in Darwin a year or so ago, identified that many of those children had unrecognised fetal alcohol spectrum disorder, and urged that children going into the justice system have a comprehensive assessment, if nothing else, to identify what their cognitive capability is. We have been asked by the community just recently to follow up the children in our original cohort 10 years on. We're interested not only in those who've dropped out of school and come in contact with the juvenile justice system, but those who have a sense of well-being, a connection to community, a connection to culture. We want to know what their quality of life is, what their aspirations are, and what could have been done better to serve their purposes. We want to be able to use our previous data to predict what led to good outcomes, not only what led to bad outcomes in these children. And that little boy that I'm with there was a boy who's now 18, and he's got fetal alcohol spectrum disorder and is running his own gardening business with the assistance of his dad. We've also recently got a grant to put in a wraparound service, including telehealth, to really try and better support these very remote communities. It's hard to understand how remote they are, but it takes me 18 hours to get home to Sydney. And they are very disadvantaged in their lack of access to health services. So we're doing all we can to have trauma-informed, FASD-informed services and to provide the access if required by telemedicine. So there have been some achievements, as I mentioned, in Australia. I mentioned the Australian Guide. We also have a hub which might be of value to people. It's called the FASD Hub. It's a sort of one-stop shop for information for policymakers, for clinicians, for parents, researchers, and it really does focus on Australian data, but of relevance to elsewhere. We've had funding from federal government for our national organisation for fetal alcohol spectrum disorder, which has a helpline for parents, and they are fabulous advocates for parents and families. We've got information for health professionals to help them ask and advise about alcohol use in pregnancy and know where to refer. We've developed resources for those working with Indigenous communities, including videos and a whole range of resources, really just to acknowledge that some of those communities are at increased risk. We've received funding from our National Health and Medical Research Council to form what we've called a Centre for Research Excellence for Fetal Alcohol Spectrum Disorder, to really try and network everyone working in research across the country. And we have a clinical network which Christine Rogan is chairing at the moment. Is that right? You're chairing? Coordinating, which brings all the Australian and New Zealand clinicians together who are working in this field, and is a very valuable resource. We have mandated pregnancy warning labels, agreed, but we haven't yet got there. Christine Rogan was heard to say it was a no-brainer, and we were all in agreement that we need these sort of labels as one way of warning women about the harms of alcohol in pregnancy. However, it's still under dispute. In Australia, we have a national fetal alcohol spectrum disorder policy strategy, and I've heard that the New Zealand one has just expired, so perhaps we need to be thinking how could that be reinvigorated, because it is helpful to have a framework to know where you're heading for the next 10 years. We have a national alcohol strategy that seems to have been in development for many years, and the problem is that the government refuses to acknowledge that the alcohol industry should not be involved in development of our national alcohol strategy. Needless to say, there's been great opposition by clinicians and public health physicians, but we're still hopeful that we will get a strategy that really reflects our views rather than those of the alcohol industry. So really, I think the future is prevention. We really need to advocate for all the evidence-based policies that Doug Selman talked about yesterday to decrease the availability of alcohol, address advertising and promotion, pricing and taxation, in addition to providing education and training, and I've mentioned labelling, and of course diagnosis and support for families who already have fetal alcohol spectrum disorder. We really need to target advertising that's targeting young women, and I just Googled this last night after Doug's talk. This is the margarita you can trust, because there's only 100 calories per glass, but there happen to be 2.6 standard drinks. So all you need is 2 of these, 2 drinks of this, and you've had a binge. And as my daughter said, but you can't taste the alcohol, Mum. And that's the problem, that young women are drinking these mixer drinks very readily without realising that some of those small vodka breezes and things have even up to 3.5 standard drinks. The media can also be our enemy, so that's a challenge. Some people say rules about how to behave in pregnancy diminish women's freedom. Advice to pregnant women on drinking is patronising and sexist. So we really do still need to have a conversation with the media and with women in the community about the reality of the potential harms, without shaming and blaming women who are drinking, and trying to identify those women who are at risk before they become pregnant. So we've got to really be back in the school age. Once they're pregnant, unplanned pregnancy, as I've said, about 50%, and many women, at least 60% of women, are drinking often heavily before they realise that they're pregnant. Now, men can't get out of it. Fathers play a critical role, or partners. We know that one of the drivers to women drinking in pregnancy is that their partner drinks or those in the household drink. So it's really important that we try and get dads or partners to make a commitment to stop drinking while their wife is pregnant. And this is an example of one campaign in Australia, the Pregnant Pause campaign, run by the Foundation for Alcohol Research and Education. And finally, we do need to get health professionals of all people to ask and advise appropriately about alcohol in pregnancy. And one of the projects I'm involved in at the moment is in a region of New South Wales where we've actually embedded the questions about alcohol in the electronic maternity records. When doctors or nurses or midwives get a score, they are then told what advice should be offered. And more importantly, they're given the local telephone numbers of the local services, and they can refer to those services. Now look, it's been fabulous being in New Zealand. It's been a fabulous experience, and I think in the FASD world we've worked together for, Christine and I certainly, for probably 20 years, Christine. But I think that we can combine forces. We can certainly be advocates together for changes to policy, for prevention policy particularly. We can combine forces with regard to training. We already have our clinical network, and we can certainly combine in research and perhaps consider a surveillance study in New Zealand to complement the one that's going on in Australia. So in summary, we really do need to acknowledge that the harms of prenatal alcohol exposure have been known for centuries, that fetal alcohol spectrum disorder is potentially 100% preventable. Nevertheless, alcohol use in pregnancy remains common. And we need to remember that women drink because of the stress in their lives, and we need to address that and not blame them for their actions. You will all see fetal alcohol spectrum disorder in your practice. You have the chance to prevent harms if you can recognise the mums and the kids at risk. We've got to remember that prenatal alcohol exposure can have lifelong consequences, but those are unpredictable. Nevertheless, they're often severe. Early diagnosis, early treatment does result in better outcomes, and we really need to take a strength-based approach, and that's why a comprehensive assessment is important, not just to identify the needs but the strengths of a child. Our approach must be culturally informed and trauma-informed, and we've really heard that exemplified this week in your conference. Australia has made great gains. In Australia, Aboriginal people have led the way. And it's really important to acknowledge that. In the future, we need to make sure there's international harmonisation of diagnostic features. We need to move towards early diagnosis, new treatments, but really importantly, we all need to be moving towards prevention. Thank you.
I just wanted to know what the projections are with regards to the stats, even though we don't have full diagnosis and a lot may not present explicitly. And the other part was, what does the World Health Organisation have to say about this as far as helping to mitigate the opposition with obviously liquor barons and legislation and such like?
So just to answer the first question, I'm presuming you mean the prevalence in New Zealand.
Correct.
And I think that we will talk about that in our meeting on Monday and Tuesday. And I think it is important to get a sense of what is the prevalence. It's very difficult to get population-based prevalence because it involves a multidisciplinary assessment that's time-consuming and expensive and involves a multidisciplinary team, but it can be done in select groups. So even, for example, in select communities or in the foster population or in the juvenile justice population. So it'll really be up to my colleagues in New Zealand to decide how to proceed there. The second question was?
World Health Organisation.
What are they doing about this whole issue? Well, the WHO has put out a guideline about how to identify and address alcohol use in pregnancy, so it's very much on their agenda. They've also funded some prevalence studies in low-income countries where it's been poorly recognised. And there is a group of people internationally who are advocating towards the WHO just for prevention messages. But I think the problem is that we know what works. We know what will prevent this and any other harm from alcohol. It's just that we need political will to accept that. And that is all very much tied up with the fact that certainly in many countries the alcohol industry has a significant impact or influence on politicians. Oh, good catch.
Kia ora, thanks Lou. Kia ora. So I've moved into a job of Oranga Tamariki, which is our welfare, our statutory organisation for children. I see lots of that and I'm really surprised by it, because I'm not saying that I wasn't interested in it before, but that we don't have research around, especially around Māori and the families that I'm seeing in the first month I've been there. The question though because when they knew I was coming to this conference, could you ask all these thousands of questions? But around the babies, a lot more babies that we're seeing coming into care are from methamphetamine families, and I'm not sure if that's going to be a bit of a study, but maybe in the future. I am concerned still about alcohol. Coming to my first cutting edge in 2002, when alcohol was and still seeing babies and families coming through this now, and a lot in our youth justice system as well, and probably all of those things I would see in the kids that I'm seeing at the moment, at the present. So what are your thoughts around?
Yeah, look, my first thought is that alcohol is almost universally used. It's the most common drug, and we know it's neurotoxic and we know it's a teratogen. So it needs to be at least considered. And what often happens in polydrug use is that we see the maternity records and they mention every other drug that was used, including tobacco, soft cheese, pate, but they don't mention alcohol because it's just so normalised in our societies. So think alcohol first. My colleagues in the States tell me that other drugs, including methamphetamines, don't cause this sort of pattern. I think the jury is still out on, for example, what impact has ice on the unborn child, and I think there is potential for research there if you're seeing a large number of ice users in pregnancy. The other drugs, such as heroin, cocaine, etc., don't cause these sorts of problems, even though they've been very widely used in North America for many years, and there are big cohorts in pregnancy. So I guess the answer is always consider alcohol, always document other drugs. There's some new data coming out from animal models about the impact of cannabis on the unborn child, so that's something that concerns me when cannabis is becoming more readily available, is that we need to be warning women that certainly there's potentially a neurodevelopmental impact on the unborn child.
Kia ora, loves. I just thought maybe I could just maybe not answer a question, ask a question, but give an answer to a couple of. Someone asked about prevalence, and commonly used stats, and there's no reason to think that we are not at this level, given our binge drinking culture, is around 2 to 5% of population. At that lower end of 2%, we're talking about 80,000 people. At that higher end of 5%, we're talking about 200,000 people. Our paediatricians that I work with say that fetal alcohol spectrum disorder is more than autism, cerebral palsy, Down syndrome combined. So we're just not seeing it. We're not recognising it. The other question around methamphetamine is that there's been longitudinal studies done in the States, and we have a longitudinal study having here in Auckland where they followed 100 children who were exposed to methamphetamine. And what the research is telling us is that, yes, there are developmental delays, but they don't have the severe cognitive impairment that we're seeing with FASD. So you're seeing much more of an ADHD type profile in methamphetamine, but not so much the real memory, language, other issues. So that those children, it was very much, there was a mediator there in terms of home environment and responsiveness of the people around them, so that postnatal environment. So I just thought, if that's okay.
Thank you,
I
Andy.
added
You can ask Andy to talk next.
I know.
Thank you.
Good.